Thank you very much. Thank you, Chairman, and ladies and gentlemen. First of all, thank you for giving me this opportunity to talk about our experiences and some of the evidences in New York City. My title of my presentation today is the role of the IVUS and how to assess the lesion morphology and how to decide the technique for the lesion preparation and finalized devices. 8 years has passed from the first study about IVUS to the randomized controlled trials. Through this 10 years from the first study about the IVUS to about the for endovascular treatment, we accumulated some of the evidences. Personally, I think the IVUS is already be a game changer with the endovascular treatment, especially for the femoral popliteal segment. This is the first study about showing the relationship between the IVUS parameter and the clinical outcomes. As you can see, IVUS evaluated minimal stent area less than 12 millimeter per square is one of the predictors for the wrist stenosis. It means insufficient stent expansion is directly related to the higher wrist stenosis rate. I think it's quite simple. It's all of you easily imagine this kind of insufficient expanded stent easily related to the highly related to the higher wrist stenosis rate. Yes, before the stenting and also after the stenting, we have to expand it, aggressively expand it, this kind of situations. Anyway, first I'd like to talk about how to finalize our treatment. Actually, IVUS is unfortunately does not have a strong evidence about how to decide scaffold or not scaffold or drug technology or not. Anyway, it means angiographic evaluation is actually sufficient to distinguish these kind of finalized devices. As you can see, if we compare the DS and DCB with a successful lesion preparation, it means no significant radial stenosis and no severe dissections. As you can see, DS and DCB show almost the same result. And as you can see, if you look at the severe dissection case, DCB showed unfavorable result. And this kind of the 10 result is continued to the over 3-year follow-up. Anyway, so how to decide DCB or DCB or DS is, I think it's easy to decide with only angular findings. However, to get the sufficient luminal area or sufficient stent area is always important, both drug-eluting stent strategy and drug-coated balloon strategy. There are several cutoff values about the DCB strategy and DS strategies. Anyway, around 12 or 13 millimeter per square is achievement of this kind of value is very important, both strategies. This is the data from our multi-center registries. As you can see, if you get sufficient luminal area, the rate of the wrist stenosis became lower. However, if you get the lower luminal area, especially for the less than 10 millimeter per square, the wrist stenosis rate became higher. Therefore, use of the adequate size balloon and adequate size achievement of the adequate size luminal area is very, very important to both strategies. Especially for the balloon-based strategy, DCB strategies, we have to always consider the recoil. Therefore, use of the larger size balloon, especially for the around the 6 millimeter size balloon, is very important. How about the dissections? Unfortunately, there is not so much evidences, but one of the evidences suggested over 64 degree of the dissection should be considered a severe dissection. Of course, if we use the IVUS during this procedure, we often find several dissections. But if you find this kind of severe dissections, please consider the additional stenting. Okay, let's move to the lesion preparations. Lesion preparation contains a much amount of the meanings to get the sufficient luminal area, improvement of the vessel compliance, or the improvement of the drug absorption. But improvement of the drug absorption and improvement of the compliance is very difficult to evaluate. Therefore, many of the people always focus on how to get the sufficient luminal area. Yes, to get the sufficient luminal area is main purpose of the lesion preparations. Calcium is strong enemy for the lesion preparations. Of course, some of the dense fibrous plaque is sometimes very difficult to expand, but calcium is the most strong enemy for the lesion preparation. There were several evidence about the evaluation of the calcified plaque. Today, I'd like to introduce some of the data from our studies. As everybody knows, calcified plaque is classified into 3 categories: superficial calcification and deep calcification. Very easy to evaluate, and furthermore, nodular calcification. Presence of the nodular calcification is also very important findings in the IVUS. Especially for the superficial calcification, presence of the superficial calcification and nodular calcification is strongly affected to the result of the lesion preparations. If you evaluate the superficial calcification, you have to focus on the depth of the calcified arc. Our data suggests that if you find the over 180 degree of the calcification, it is a very highly strongly associated to the lesion preparation failure. Therefore, in this kind of situation, we carefully consider the special technique for the lesion preparations. And also, this kind of deep calcified arc is highly related to the higher restenosis rate. Furthermore, as I already mentioned, presence of the nodular calcification is strongly associated to the lesion preparation failure. Then how should we decide which is a better strategy for lesion preparation for each lesion? We distinguish several lesion preparation devices, 2 categories. One is a debulking-based strategy, the other one is a balloon-based strategies. Debulking-based strategy can be reduce the volume of the calcium. Balloon-based strategy is difficult to reduce the volume, however, easy make the crack without any risk of the distal embolizations. As I already mentioned, debulking devices reduce the volume. However, it always contains the risk of the distal embolization. How to distinguish these strategies is very, very important. Unfortunately, in the IVUS findings, we cannot evaluate the thickness of the calcium. In the field of the coronary interventions, use of the OCT or FDI can evaluate the thickness of the calcium. Therefore, if we utilize this kind of the several lesion preparation devices, use of this kind of the more adequate imaging is sometimes needed. Anyway, there is no sufficient evidence-based lesion preparation method. However, this is one of the suggestions. If you find the angiographic calcification, please consider using the IVUS, because distinguishing deep calcification and superficial calcification is impossible with only angiographic findings. If you use the IVUS, you can easily distinguish both. If you see the less than 180 degrees of calcification or no calcified nodule, lesion preparation with simple angioplasty is often sufficient. However, if you find over 180 degree or calcifications, I think it is a very good indication for the balloon-based strategies. If you find the nodular calcification or more severe calcified arc, please consider the debulking. It's the only way to reduce the volume of the calcium. Thank you very much.